Thank you very much, Professor Mucano. Again, I would like to thank Merck for organizing this nice and educative meeting. The topic of my presentation this morning is not the luteal phase, as we discussed yesterday, is the follicular phase, because as you have seen, we can individualize not only the luteal phase, you can also individualize the follicular phase, and of course, you can also individualize the final oocyte maturation. Disclosures, but for the current presentation, there is no conflict of interest. In fact, if you take a look at the female reproduction, it's a very inefficient system. A baby girl or a woman who is pregnant with a female baby at the 24 weeks, 25 weeks, has around 7 million eggs. It's a huge number. You would say, who wants to have 7 million children? The problem is, the moment that baby is born, she has 1 million. It means you start with 7 million, and with the birth, you go to 1 million. You might say, still, who wants to have 1 million children? The problem is at that time, that baby is not ovulating. There is no period. So the period starts at the age of, let's say, 12, 13 years. And at that time, that girl will have maybe 300,000-400,000 eggs. Still, you might say, 300,000 eggs, who wants to have so many children? Now, in your whole life, from the ovulation until you go to menopause, you will use around 400 of these eggs. And almost half of these eggs during your lifespan that you're going to use will be chromosomally abnormal. So as you can see, it's not a very efficient system. You start with 7 million, and you end up with maybe 150, 200 of chromosomally normal eggs. And if you would have a look under the microscope, this is what you would see at different age categories. Now, what we used to do, we used to define age as the biggest predictor of response. But you know that you can be a young lady who is a good responder. You could be an older lady of 40 who is a good responder. But you could also be a 25-year-old poor responder. So age is not the only predictor of response. Age is one of the predictors, but at any given age, you can have a high response, medium, or a low response. And there are various factors which are interfering with the response of those patients. Today, if you ask me, how important is sperm? And of course, andrologists and urologists would oppose this statement. How important is the egg? And how important is the uterus? Of course, all of them are important. But you know, the old Romans, they used to say, life comes from the egg. And I think they were right. The egg is the most important part contributing to a pregnancy. If you ask how important is it, I think this graph is demonstrating it. Egg has the biggest importance of developing to an embryo, and endometrium is of course also important, but the importance you see in this graph, the biggest importance goes to the egg. Now you have seen this slide from Sek yesterday, who used huge databases of HFEA in the UK, and she came out with a statement that in fact you need to have somewhere around 15 eggs to be successful. You see 15 eggs with whom? 15 eggs with a 45-year-old, 15 eggs with a 25-year-old. And the more important question is, how was this patient stimulated to get these 15 eggs? You see, the stimulation itself is also extremely important. Because if you stimulate and you create an abnormal endocrine environment, possibly damaging the quality of eggs, of course you will see a drop of the quality of the eggs. And I think this is an old study, Van der Gaast, 15, 16 years ago from the Netherlands. It's exactly the same thing. You see 15 eggs, and suddenly you see a drop of pregnancies. And this is more or less what you see in the bigger sample size. You see 15 eggs, and there is a drop. Is there really a drop? Is there really a cutoff number that you say, okay, 15 eggs and you go down, the pregnancy rates go down? It depends how you stimulate in order to get these 15 or 16 or 20 eggs. So we published this paper in Human Reproduction, it's already now 8-9 years ago, where we demonstrated the opposite. We see the more eggs we had, the higher was the pregnancy and the higher was the ongoing pregnancy. So it's again in contradiction of what has been published before. But why is that? Why do we have so many contradictory publications with the same question but different outcomes? And this again goes back to the detail. Important is how you stimulate in order to get this number of eggs. Now, this is a beautiful study published in FNS a few years ago from the US. You know, patients always ask us, how many eggs do I need to have a baby? And this study is exactly answering this question. So what they did, they said, look, if you're between 30 and 34, and you want to have one child, let's say you have 12 eggs, your chance of having one child is around 70%. But imagine you are 36 or 37, with 12 eggs, your chance is around 50%. So you have a drop of 15-20%. But let's go further. Let's say you are 42 years of age, and you have 12 eggs. You see, you suddenly drop from 70% of 30 years to 20%. So with the same number of eggs, you suddenly have much lower chance of having a baby. And the other lines that you see is having at least 2 children or at least 3 children. Let's keep it with 1 child only. So you see, if you're focusing on the number of eggs needed to have a live birth, there are 2 questions you need to ask. What age of patient? And secondly, how was this patient stimulated? And the topic of our presentation today is exactly how the stimulation should be conducted in order to keep the quality of the eggs at a good level. Now, why is that we see a drop of live birth with the same number of eggs with aging patients? Very simple, because you have more aneuploidy. You have more chromosomally abnormal oocytes. You might ask, why is it possible that women's eggs are aging, but with men, you don't have any chromosomal abnormalities with the sperm, with the aging process? The answer is very simple. Women are born with this number of eggs, and they are there. From the moment they are there, they are there. But men, they have a factory of producing sperm on a daily basis. So even if you are 60, 70, 80 years, every day, new sperm is being produced. So it means this sperm is not aging. Of course, you have more single gene disorders with aging and DNA damage, but chromosomal abnormalities are rarely present in a sperm. So what you see here clearly, and this is a huge database from Jason Fanzig from New Jersey in US, what they did, they looked at the prevalence of abnormality, and you see at the age of 42, 43, 90% of the eggs are chromosomally abnormal. This is huge. 90% of the eggs are chromosomally abnormal. Now, if you take a look at the pattern of abnormality, and this is exactly what I was mentioning, because we focus a lot on the sperm and abnormalities of the sperm and so on, it is important to understand you need to distinguish between mitotic and meiotic abnormalities. This is a very important point when we speak about mosaic embryos and so on. But interestingly enough, you see paternal meiotic abnormalities are extremely rare. It's maybe 1 or 2%. It's very, very low. On the other side, if you take a look on meiotic maternal abnormalities, from the age of 34, 35, they suddenly jump up. And meiotic abnormalities do not have any self-correction because they are in the egg. There is no self-correction. Those mitotic abnormalities are the abnormalities which are going to self-correct themselves the older the embryo gets, day 2, day 3, day 4, day 5, and so on. But meiotic abnormalities do not self-correct themselves. And I can tell you currently there are a couple of studies ongoing in Maastricht in the Netherlands looking to distinguish between meiotic and mitotic abnormalities in an embryo. Now, we know that a successful pregnancy is a good synergy between a good quality embryo, genetically normal embryo, and a receptive endometrium. So you need to have all these variables. If you have a receptive endometrium, you don't have a good embryo, it will not work. If you have a good embryo and a non-receptive endometrium, it will not work. So we need to try to synchronize embryo and endometrium together. And our knowledge on this window of implantation has been very limited. You see, the first publications, you have to imagine the first publications speaking on window of implantation were from 1973. And still today, we refer to many of these publications from 1973, and we say, look, the window of implantation is 4 to 5 days. And I can tell you, through gene expression models today, we understood that the window of implantation is much more narrow, maybe 2 days, maybe 1.5, maybe 2.5 days. There are individual variations, but it's around 2 days in average, you can say. So it's not 5 or 6 days as we thought it was. So when we are stimulating a patient, obviously we create a completely abnormal environment, and we physicians, we like to simplify things. So what do? When a patient is asking us, doctor, are you happy? Yes, I'm happy. Look at the scan. Your endometrium looks perfectly fine. But is this really a receptive endometrium? We don't know, because we are simplifying, just measuring the thickness and the shape of the endometrium. But the question is, what is happening histologically in these cells? Is the endometrium being well prepared? Is the exposure to the steroid hormones well calculated in order to reach these, let's say, 48 hours window of implantation? Now we know that the intrauterine cytokine profiles between a stimulated cycle and a natural cycle are two different pair of shoes. You cannot compare a natural endometrium with a stimulated endometrium. The moment you start administering gonadotrophins, you have supraphysiological levels of steroids, your hormones are going up, you change the environment of the endometrium. And you see here clearly all these factors which are responsible for implantation, they are completely modified. And these are beautiful studies, and I think yesterday there was a question, and I think this is the answer of the question. What happens if you stimulate a woman? Very simple. Your endometrium is advanced. Why? Because the moment you stimulate and you have 2-3 follicles, you give the trigger shot, within 2 to 3 hours your progesterone shoots up. When the progesterone is shooting up, your endometrium is exposed to progesterone. So what happens? If you compare a natural endometrium with a stimulated endometrium, you always have at least 33, 34 hours of advancement, at least. But there are patients, they have advancement of more than 2 days. They have advancement of 3 days or more. Now, what happens with these patients? Very simple, they don't get pregnant. So if you have a patient who is exposed to progesterone longer than required, because she's already exposed to high progesterone after the triggering, so if this progesterone is elevated before you administer your final oocyte maturation, what will happen? The endometrium advancement is more than 1.5 days. It's going to be 2 or 2.5, maybe 3 days. And that will lead to a lack of pregnancy. And all these data have been published. I mean, this is nothing novel. You see, these publications are from 20 years ago, approximately. Now, going back to progesterone, what is the role of progesterone? You have heard yesterday, progestation, hormone for pregnancy. Obviously, this is the hormone for the luteal phase and for early pregnancy. Good. But what does it do in the follicular phase? Now we have to go back to basics in order to understand what we do when we stimulate a patient. Now, the moment you stimulate a patient, obviously these follicles are growing. The bigger these follicles become, the more progesterone they produce. That is given. We know that. So a follicle of 17, 18 millimeters produces more progesterone than a follicle of 11 or 12 millimeters. So bigger size follicles, more progesterone. That is what we know about progesterone. And we know that if progesterone is elevated in the follicular phase, you change the gene expression of the endometrium. This is a paper we published with Inge van Varenberg. I think Professor Blockel was also co-author with us in that paper, where we looked to the gene expression of the endometrium, patients being stratified in different levels of progesterone on the day of final oocyte maturation. The group with low progesterone, medium progesterone, defined between 1 and 1.5, and progesterone of more than 1.5. So what we saw is that when progesterone starts to get elevated, we have a significant increase and difference in gene expression. So your endometrium is totally changed. And what happens if progesterone is elevated? You have seen the endometrium is more advanced. If the endometrium is more advanced, simply you have a drop of your pregnancies. So this is from Ernesto Bosch from Valencia. And after that, there have been many, many publications confirming these findings. Now you would say, yeah, but I'm happy with my lab. I have good embryologists. I have really a good lab. I don't care about the endometrium. I am going to freeze all and put these embryos back in a HRT or natural cycle. Now the problem is that progesterone, and this is currently being debated again, like everything else, but in the next few years we will understand that this has also a negative impact on the oocyte quality. The problem is that in every age level, every quality of embryo level, and every number of oocyte level, there is a drop in pregnancies the higher progesterone you have. So high progesterone seems to be detrimental for pregnancy rates, for endometrial advancement, and it seems somehow to be related to the egg and or embryo quality. So do we really impact only the endometrium? Apparently no. It seems also to have an impact on the oocyte quality. And as you can see, top quality embryos going down, and these are two different studies published by Vani and Huang. And also some studies came, again, contradictory studies. This is from Brussels with Christophe as the last author, and I think they recently published another paper contradicting this. Studies going right and left, stating yes, difference, no difference, but it seems that it has somehow an impact on the quality of the embryos. Now, some people have said, maybe this progesterone is being elevated because we have a lack of ACG activity. You know this study which was published 15, 16 years ago, comparing HMG with FSH, and they said, hey guys, look, because you don't have ACG activity, you have premature progesterone rise. But what they did as a mistake, you see the progesterone in HMG group was indeed lower, and the difference was statistically significant, but a mistake they did, they triggered the patients in the REC FSH group significantly at the bigger size follicle as compared to the HMG group. Now, the basic knowledge is, the bigger the follicle becomes, the more progesterone it's producing. So if you trigger this group at a later stage, of course you're going to have more progesterone because you have triggered at a later stage. So is it really because of ACG or LH activity that you prevent the premature progesterone rise? Now, in their belief, the same group which published that did a study. They said, look, guys, ACG is preventing a premature progesterone rise. So let's do a study, and we just give patients ACG. We give FSH, then we give no ACG. We give 50 units of ACG, 100 units of ACG, 150 units of ACG. And in their perception was, the more ACG they administer, the lower would be the progesterone during the stimulation. And guess what? Of course, the opposite came out. Because ACG is not preventing a progesterone rise. ACG is contributing to the progesterone rise. So that was a total wrong approach, but fortunately confirmed by the same group. And I can tell you today in some congresses, when you go around the world, still people are referring to these papers, ACG is preventing premature progesterone rise, which is total nonsense, because that's not the fact. Now, why does progesterone go up in a stimulated cycle? Now, others have compared with different protocols, adding LH or no LH, they looked to progesterone levels, there was no difference. In fact, something which is interesting, you see, progesterone seems to be linked to LH receptor expression. So the more LH receptors you have, the higher is your progesterone. Again, confirming that ACG or LH are not preventing this progesterone rise. They are contributing to the so-called progesterone rise. Not only the LH receptors, but also the LH levels by themselves are contributing to that. Now we looked back again to old studies and looked, okay, what kind of patients have high progesterone? And it seemed to be patients who are really being stimulated severely. So based on that, with Dimitra Kirou, we published a paper, said, look, if you are giving too much of FSH, that is possibly the reason that you have premature progesterone rise. So we are the reason because we are pushing the follicles too much. And indeed, the more FSH you administer, the more LH receptors you create. So the more FSH you administer, the more LH receptors you create. This is very important. And these LH receptors obviously are contributing to progesterone production. Now imagine you start from cholesterol, you have a lot of enzymes. And if you give FSH, you start producing estradiol. But imagine you are putting more and more pressure to these follicles, to these enzymes, to produce more estradiol. At some point, they cannot produce more estradiol because they are working on full capacity. So instead of producing estradiol, what will happen, they start producing progesterone. And this theory has been reconfirmed that if you have too much of FSH, especially towards the end of the follicular phase, what will happen? Your progesterone is going to be elevated. Now, looking into ovarian stimulation, and you have to look, what does nature do? What do we do? Now, nature stimulates basically here somewhere, 4 or 5 days before you start bleeding. FSH goes up. When the follicle has been recruited, FSH goes down. What do we do with ovarian stimulation? We start maybe day 1 or 2 or 3 of the cycle. We give FSH, but the moment we pass the threshold, we continue until we trigger. It means we are accumulating FSH. But in fact, if you would mimic nature, stimulate, and do a step down, what would happen? You will see that you are completely going different ways with stimulation. So nature goes up and goes down. What we do, we just go up and up and up. Now, what is the impact of this? The impact is that if you would do the step down, you seem to have less follicles. If you follow this pattern of stimulation and step down, you will see a significant drop of premature progesterone rise. It is almost not present. You can almost, I would say 100%, prevent completely a premature LH rise. You just have to respect nature and doing the step down. And as you can see, based on the FSH levels that you have on various days during the stimulation, you can prevent a premature LH rise. This is a paper we just published, I think 3 or 4 months ago. What we did, we gave to the same patient population the same dose of FSH. And we measured exactly at the same time of the day the systemic FSH levels. So imagine we had Mrs. X, she was 35 years of age, with a BMI of 25, with a certain ovarian reserve. We gave at 8 p.m. rec FSH, at 8 a.m. antagonist, and at 12 noon, we measured how much FSH do we have in the systemic circulation. And we were astonished to see the differences, really astonished. Same patient, same demographics. You will have patients who have an FSH level of 7, I'm going to repeat myself, 7, which is physiologic value on day 6 of stimulation. And the same patient with the same demographic will have an FSH of 27, which is very high. You want to keep around 15, 16, 17. That's what you want to do. So you see, these are the areas we have to look at. The huge variation that we have. And this is not linked only to BMI. It is not linked to ovarian reserve. This is linked to the metabolism, clearance in the liver, in the kidney. These are factors we completely neglect. We have no clue about these things. So we just published a paper 3-4 weeks ago in RBM Online, where the title of that paper is Reintroducing FSH for Ovarian Stimulation, because everyone is different and the response will be different. So what will happen if you have too much of FSH at the higher level? Obviously more FSH, more progesterone, less endometrium, and apparently also lower embryo quality. Also, the length of stimulation seems to have an impact. We published few papers, review articles on this topic if you're interested on that. So I think we can conclude. I'm sorry, we are going very fast. So the moment you stimulate a patient, you change the endocrine profile, the endometrium is advanced. That's a given fact. Endometrium is advanced by at least 1.5 days, at least 34 hours. Progesterone, it has an impact on the endometrium. It seems also somehow have an impact on the oocyte and embryo quality. And this is independent if you're using agonist or antagonist. This is based on the amount of FSH you administer, not in the beginning, especially the last 3-4 days of stimulation. And keep in mind, nature is doing a step down. Of course, you all would be worried, if I do a step down, the follicles will go to in regression. Keep in mind that the follicle of 14-15 millimeters has almost no FSH receptors. It's 95% only LH receptors. And when we speak about individualization, it means we need to adjust the dose according to the patient's response. If you're interested, we just published a book with Cambridge University Press where we describe a lot of steps of these luteal phase and also follicular phase adjustment. Thank you very much, and apologies for the couple of minutes delay.
Thank you. Thank you very much, Professor Fatemi, for this presentation on the risks of stimulation or sort of uncontrolled stimulation or unthought stimulation. I do have sorry, maybe we start with questions from the floor, please. Anybody wants to ask a question? While people warm up, I have one question. When we look at aneuploidy in relation to a patient's age, we see sort of a boat-shaped curve. It's obvious why the curve goes up on the right. I'm asking the question, do you have any explanation why women that need IVF in the 20 to 25 bracket age do far poorly than women 25 to 35, both in outcomes and higher aneuploidy? Do you think it's in the stimulation, or do you think it's something organically wrong with those patients that they need IVF at 20 to 25? That always fascinated me. I don't know if you have a question. But
you see, those patients who we see at the young age, I think there are two variables which are responsible for aneuploidy. And there are two beautiful publications, one of them from Renato Fanchin from Paris in FNS, the other one from La Marca, Italy, FNS. There are two variables which are important for aneuploidy. And it's not only age. It seems that ovarian reserve, independent of age, is also contributing to aneuploidy. So most probably those young women who are visiting a fertility clinic where we are collecting the data, they are there for a reason. Most probably they have also some issues of getting pregnant. And most probably this issue is linked to ovarian reserve, that the ovaries are aging faster than they should age, leading to more aneuploidy. But I think it's also important to realize there have been many publications recently. Women at young age with repetitive miscarriages, obviously they seem to have a DNA cell repair damage mechanism or low ovarian reserve, are also at risk later to develop other diseases, other malignant diseases. So I think this is somehow linked together. The fact that they have at the younger age lower ovarian reserve, leading to possibly more chromosomal abnormalities, seeing beautifully the shape that you clearly described.
Yeah, because it's important to keep in mind when we stimulate very young patients.
Absolutely.
As we'll say, okay, she's very young, she should have plenty of eggs and good quality embryos, but that might not be the case.
Yeah.
Thank you. So questions from the floor, please.
I just wanted to ask about, you showed very nicely how elevated progesterone is correlated with poorer outcomes. But just one more time to clarify, do you think there's a causal relationship or is it a marker for a bad stimulation?
That's a very good question. I always say it's a marker, it's a red light. It's like you are driving with your car, a light goes on, you still drive, but something is cooking in the back. I think absolutely it's what you clearly said, it's a marker of bad stimulation. And the progesterone itself, this is not bad. I mean, if you look to the dual stimulation in the luteal phase, you have beautiful eggs, beautiful embryos, because that progesterone is coming from a corpus luteum, not from that follicle. So the fact progesterone is being elevated, it is a sign, it's a marker, hey, we are doing something wrong. And it's not the progesterone per se. Yes, the progesterone has an impact on the endometrium. We know that progesterone around 0.91 is contributing to the endometrial advancement. I think the worst part is what is cooking behind. It means you are giving too much FSH. Too much FSH means you are creating more LH receptors. If you are having more LH receptors, the moment you trigger with agonist or ACG, the more receptors you have, the faster is your final oocyte maturation. The faster is your cytoplasmic maturation. And that possibly is leading to lower egg quality. We have had last year at ESHRE an abstract where we linked this high progesterone also to more aneuploidy independent of age. And this year at ESHRE, we have something similar that we're going to submit. And actually, I have to review the paper in the plane today. But we are looking also into that there is possibly a link. It's a marker. It's a light going on. It's not the progesterone. It is what is cooking behind.
Thank you. Further questions from the floor, please?
Don't you think that high doses of FSH can be a marker of the woman as well? So what is the woman, what is the duration of the stimulation rather than the FSH dosing and the follicle count?
Yes.
So patients with low egg quality not only stimulate bigger follicle size, trying to get another pure follicle instead of triggering at the right time. But there are many.
Yes, you are right. So basically what you say is that these high levels of FSH might be a sign of the patients that individually she needs higher levels of FSH. You know, the paper I showed you with Barbara Lawrence, we looked also into the length of stimulation, and the length of stimulation is also linked to higher progesterone, lower egg quality. The thing is, when you say, I have a patient, first of all, Casper published a paper, when you reach an FSH of, I think, 24, 25, you have covered all the receptors. If you have FSH of 30, 35, 40, and I can tell you it happens very often, the patient is just clearing it in the kidney and liver, and it's not used at all. But the patient who is having these long responses, obviously this is a sign of bad egg quality because it's really getting long. On the other side, if we give too much of FSH, it's also not good. So there is a certain level. The question is, what is the best level for what patient? We don't know. But you're right, everyone would require a different dose. But I think in the beginning, we cannot do too much harm. In the beginning, you want to recruit these follicles. You want to recruit them. But once they have been recruited, I think the mistake is we continue pushing and we are afraid of doing this step down. And that is the mistake. You know, when we have new physicians joining us and they see what we do, they just close their eyes, they just run away. Say, no, this follicle is going to go to regression. You know, a follicle of 14 millimeters, 14 or 15 millimeters, it has barely FSH receptors, barely. It has only. Christophe published a paper, when you have follicles of 14, 50 millimeters, you just stop completely your FSH. Just give 200 units of ACG. And those follicles will continue growing. Filicori did the same. There are many publications out there stating you don't need that massive amount of FSH at the end of the stimulation. Why do we do that? Dogma, because we have learned it that way.
Thank you. There are a few questions that are typed in, so I might just ask them if you don't mind. What is the optimum number of oocytes in your opinion, considering everything that was discussed?
I mean, that's a question that I cannot answer to. It is based on the age of the patient. It's based on the stimulation. I think if you want to simplify for any given age until 42, 43, if you harvest 14, 15 eggs as SEC published, then you might be on the safe side. But is 15 the same for a 25-year-old and a 42-year-old? Absolutely not. So this is something which needs to be individualized according to the patient's past history. See, does the patient have good egg quality? What is the ICM quality? What is the embryo division pattern? How does the uterus look like? So there are so many variables that there is no clear answer to that question.
Thank you. Is there any proof of a relation between low AMH and poor oocyte quality, independent of age?
That's a very good question. And this, again, is being debated. You will have some. And I think Juancho published a paper recently saying, look, AMH is not really important. It is more age. We have data showing exactly the opposite. And this is the beauty of science. You see, you have a lot of publications with different outcomes. Personally, I think if you have low AMH, you have to ask the question, why is this AMH low? If you have a 25-year-old patient who has been operated because we as surgeons were very aggressive and we burned the whole ovary and she has low AMH, the remaining eggs still will be of good quality because she has low egg quality because we destroyed it. But if the patient has a mother who had breast cancer, has DNA cell repair mechanism damage, AMH is low because she has some genetic issues, of course here, that patient would have much, much lower egg quality. So we need also to identify, if you have a low AMH, why is it low? Is it because of endometriosis? Is it because of the surgical procedure? Is it because of cancer in the family? Is it because of genetic predisposition? You see, these details at the end will make a difference. You cannot say 25-year-old with a low AMH. Then you have to ask, okay, why is the AMH low? And I think that is the key question.
Thank you very much. Thank you so much, Professor Fatemi.
Thank you.
We're closing this session. Thank you.